Hello again. Thank you for giving me the opportunity to share our humble experience in Northwest Syria. I would like to talk about adapting simplified technology to improve mortality data for Northwest Syria. I will start by giving a background for the context. The ongoing conflict has divided the political map in the country. Northwest Syria is located here. The region is outside the regime control and hosting the most populous region, the most is considered as the most populous region in the country, hosting around 4.5 million population, and 2/3 of them are internally displaced persons. Those persons are mostly dependent on humanitarian aid, receiving health services from humanitarian NGOs. The public systems in the country are disrupted, and there is absence of civil registry and vital statistics, the CRVS. Also, limited and poor data on mortality in terms of the three determinants of the quality of mortality: the coverage, completeness, and accuracy. Under investment in health information systems and health measurement. The HIS unit, which I'm working for it, is a local entity working to fill a vacuum left. I'm going to speak about the first tool to collect the data of mortality in the field. Firstly, the deployment of the DHIS2, which is an open source software developed by Oslo University, and it is used widely worldwide in the LMICs. Through this platform, we are applying a standardized death certificate, and we collect MCCD, the data of medically certified causes of death. Doctors are trained on assigning the cause of death using the ICD-10 shortlist. The paper-based data is transferred to the DHIS2 platform, and a photo of this standardized certificate is also attached for validation purpose. At the central desk, the administrative data and cause of death are reviewed, processed, and then analyzed, and then reports are disseminated to the end users. Here is a slide that shows the stages in this process, started by customizing the data collection forms on the platform. The data entry clerks receive data from the doctors, the paper-based data. Then the data is transformed to the DHIS2 accordingly. After that, at the central level, the data is reviewed, processed, and the leading cause of death is reassigned. The analysis is made, and the reports are disseminated. The second tool we have adopted for Northwest Syria is verbal autopsy, which is mostly explained by other colleagues, Dr. Flaxman, Dan, and Ahmed, is an alternative tool in settings of weak CRVS or MCCD. Data on cause of death are collected through an interview with the next of kin. We have used the WHO 2022 instrument, which includes questionnaire, list of cause of death, and the rules and guidelines. And by the way, we were the first country who translated this tool into Arabic language. The interviewers used Kobo toolbox for data collection. After that, the assigning of the cause of death was made through physician-coded verbal autopsy, the PCVA, instead the computed coding verbal autopsy, CCVA. We implemented multi-cluster stage sampling for 5 regions in northwest Syria. to which may be representative to the whole region. After that, we have integrated the data of verbal autopsy and the data coming from the DHIS2. The data was compiled into a single database where the VA classification of causes of death was applied. The analysis was conducted then, and the results were presented in an interactive report using a Power BI tool. Through this tool, we have presented dashboards, including the geographic distribution, age, gender, and the ranking of causes of death. In addition, we have developed a technical narrative analytical report from this data. Here is a dashboard that shows the distribution of deaths, the age groups, gender. The source can be filtered if it is verbal autopsy or MCCD. And the analysis for the causes of death was made for 3 levels. The 40 groups, group 1, 2, 3, or unknown. The group 1 means infectious diseases, maternal diseases, and prenatal deaths. Also, group 2, the NCD. Group 3, the injuries. And here is the analysis made for 7 groups and the analysis for 13 groups. The last slide is our humble vision for how can AI bring about for the quality of data, the quality of mortality data in fragile settings. AI can increase the coverage by improving the notification, adopting like something like that akin to the EIOS, the epidemic intelligence of open sources, by bringing data from rumors, social media, and different sources. The completeness can be increased by the AI through merging the different sources of data, and the accuracy of the cause of death, either for the application of the death certificate by applying the validation rules and better application of the sequence of events in the death certificate, which we have noticed. Also by improving the VA algorithms and the narrative text, the words, by capturing the words of the narrative text to improve the accuracy of cause of death.